Dr. Espinola, and we're super excited to have her. So I'm going to go ahead and go over some of her background real quick, and then we'll get started with her presentation. So Dr. Espinola is a licensed psychologist with expertise in diversity, women's issues, and trauma. She was born and raised in Argentina and studied psychology at the University of Buenos Aires before immigrating to the U.S. in 2001. She completed her doctorate in clinical psychology at Nova Southeastern University, her predoctoral fellowship in multicultural psychology at Boston University Medical Center, and her postdoctoral fellowship in trauma psychology at McLean Hospital and Harvard Medical School. Dr. Espinola is an assistant professor in the Department of Psychiatry and Behavioral Neuroscience at the University of Cincinnati College of Medicine. She is also a media psychologist and has over 25 awards for leadership, diversity initiatives, innovation, and community impact. Dr. Espinola has been featured on multiple media outlets, including ABC News, CBS Fox, and NBC News. She is the co-founder of the UC Latino Faculty Association and serves on the UC President's Diversity Council, the Cincinnati Youth Collaborative Board of Directors, and the Health Policy Institute of Ohio Board of Directors. She is a faculty advisor to the UC Student-Run Free Clinic and UC Biz Mentors. Thank you, Dr. Espinola, for coming and joining us today to talk more about your experience with mental health care and marginalized populations. I will also put a link to her website in the chat.
Hi, everybody. Thank you for inviting me. I want this presentation to be more about giving you examples of some things that are possible, and then get everybody excited about maybe engaging in similar projects in the future. But it will be more of a brainstorming session, if you will. And then hopefully we'll have plenty of time at the end for questions and a nice conversation, okay? All right, so first, a little bit about me. I was born in Argentina, in Patagonia, very, very far away, near penguins and the South Pole. And growing up, when I was born, there was still a military dictatorship going on at the time that ended when I was still very little. But that historical event significantly shaped the course of my life because everybody around me had been through this brutal dictatorship, and everybody around me had developed just a lot of passion for promoting democracy and human rights, right? So my teachers felt that way. A lot of people in the community felt that way. And my favorite cartoon, so I grew up looking up to this little girl, and I still do. It was just still my favorite cartoon is, her name was Mafalda. And this little girl will be passionate about promoting human rights and democracy. and a lot of people call me Mafalda too, because that's what I always been that way. And then when I immigrated to the United States, which has been 19 years now, almost 20, I started wondering so growing up, because I was looking up to Mafalda, and I was just thinking all the time, okay, what can I do to change the world and to make an impact and do something significant, for the lives of others. When I came to the United States, I started looking at what could I be doing here? What needs some repair, some healing, some change? And of course, I came across the healthcare system, and I started looking more into this. And the first thing that shocked me at the time was that people were actually dying due to lack of healthcare, which was mind-blowing to me. I never thought I would see it here in the US, because Mafalda, she believed that healthcare was a right, a human right. And that's what I grew up with. That was my belief, and it still is. And so here are some this is from the American Public Health Association, and I'm sure all of you know already, but the US spends more on healthcare, but has worse health outcomes than comparable countries around the world. And then within the US, there are unacceptable disparities in health by race and ethnic group. So after living in Florida, as I was mentioned, I lived in Boston also. I came here to Ohio about 5 years ago, and I did the same thing that I always do, just looking at, okay, what can I do here? What is needed here? What should my attention be placed? Because I feel like there's a lot going on everywhere, but you have to come up with priorities. And I look at healthcare, and I saw this, and I was even more shocked because I already knew the U.S. healthcare system was bad, but then Ohio actually ranked among the worst states for this. So specifically when it came to public health and prevention, it ranked 50 out of 50 states. And now it's a little bit better. I think we are at 47 now, but it's still disastrous, right? Like, how is this even taking place? And then I looked more, specifically because, I mean, one of my issues is obviously ethnic and racial disparities. So I want to see, okay, so what about, how are minorities faring here? And again, Ohio ranked among the worst states. And some people kind of like, it catches their attention very often that Kentucky, for instance, doesn't. So it's not great, but it's still like, it's a lot better than Ohio. So why is this? It's because like, it's not that Kentucky's healthcare system is great. Like, we know that. Not at all. But what we are looking at here in this map specifically is that are the average differences in quality of care for Blacks, Hispanics, and Asians compared to whites, right, by state. So it's not that their healthcare system is great. It's like, it seems like everybody gets access to the worst healthcare. So the differences are not significant because, all races and ethnicities seem to be getting very poor quality healthcare. In Ohio, however, is different because you see some populations, great hospitals here. We have Children's Hospital and the Cleveland Clinic, and so it's kind of hard to believe for people that Ohio would rank so badly in the healthcare system in the country. But partly is because there are some people who are benefiting from going to these hospitals and getting this great access to healthcare and access to great quality of life, while others are living in conditions that are in many cases worse than places in the third world. And I'll show you, because that's another thing that is really, really hard to believe. But in 2018, so I began, so about, I think 3 or 4 years ago, I was called to serve on the Ohio Commission on Minority Health. And which was a great experience there. And I had the opportunity to meet people from all across the state who were passionate about this, who were passionate about making a change. And I came across this organization, the Health Policy Institute of Ohio. And this is a nonpartisan organization, a nonprofit organization that analyzes data in Ohio and proposes different public policy changes. Eventually, I was very fortunate to be invited to serve on the board, so I've been serving on their board. And this is one of the studies that, I felt like was so significant and so important. I think everybody should take a look at. What they found here is that there are people in Ohio right now who are expected to live about 61 years. 61 years. And just to put this into perspective, I took a picture of like some other countries that are like around that, or well, actually countries that are doing better. So in Tanzania, for instance, so people are expected to live about 66 years. Okay. So 61 years is equal to the amount of time that people are expected to live in Congo. This is how catastrophic this is. While others, however, are expected to live 89 years, right? So these are the disparities that I am referring to. So where do we go from here? What can we do? And there's so many things that we can do. So that's what I want to focus on. One thing that I obviously do is, as a clinician, I provide individual treatment, which is very meaningful to me. And I'm sure a lot of you are focusing. I mean, I know that many of you are medical students or are planning to be clinicians in the future. So that would be one way where you can significantly impact people's lives, face-to-face, right there. The con of individual treatment is that there's only so many people you can see, right, face-to-face. There's always a limit to that. Then group treatment has been another approach that I have taken as a student. So when I was still a student, I came to Ohio actually like 7 years ago, or 7 or 8 years ago, but just for 10 months or 12 months. And I work in a clinic where most people have very severe physical illnesses and mental health disorders. And we had such a huge wait list. It was just horrible. And it was the beginning of the opioid epidemic, and a lot of people were very desperate to get medications for chronic pain, for the pain that they were experiencing, the emotional and the physical pain, both. And at the time, the psychiatrists wanted to stop the amount of medications that we're prescribing, because they were taking note of like, this is getting out of control here. And this is a population that live in poverty. Most of my patients, they are lived in very deep poverty. And then they were struggling a lot. Many of them with suicidal and even homicidal ideation. So I said, okay, I need to do something like urgent. Like I have to take some type of different approach than what we're doing, because I can't just keep seeing one person at a time. That is just not going to cut it. Like we need to do something more drastic. So what I did, I proposed to the management to start doing group treatment. So I created about 6 different groups. And what that allowed me to do was and I started taking as many people as possible out of the wait list. I started conducting intakes. And then I would assess them depending on the urgency. So some people and the severity of their symptoms. So obviously suicidal and homicidal people were first, right? And those were the ones getting most of my attention. And then there were a lot of them who didn't need that. I mean, they had very severe issues, but they were not at that level, at the extreme urgent level, right? So with them, I had individual therapy, but a lot of group therapy as well. So that allowed me to open up more slots. And then there were people who just needed to be heard once and then get access to group therapy, and they were okay. So that facilitated the opportunity of serving so many more people than just one person at a time. Then there is the part of the community initiatives that I'm going to talk about, and then institutional policies in academia and what you can do with that, public policies, and finally media and technology. So I'll share some of that. So in terms of community initiatives, when I came also to Ohio, back in Florida, though, I started working with survivors of sexual exploitation, commercial sex trafficking, domestic minor sex trafficking. And I mean, I always work with victims of trauma, and that was a population and that I put a lot of my attention to. And this is a mix of, so that is referring to it started off as an individual treatment. So I started seeing girls in juvenile detention centers, and I started hearing from them that they had been arrested for prostitution. So that caught my attention, because some of them were as young as 12. So it just didn't make sense to me. How is that even possible? Right? It's not even, so they are not legally able to provide consent, but somehow they are being charged with prostitution. It makes no sense to me. So I started to investigate a little bit further, and I found some organizations that have noticed that. So I partnered with many of them, and then I started advocating for a change in the law, because I figure, when the system is sick, you need to treat the system. It's not enough for you to do face-to-face. And in fact, doing face-to-face when you know that the whole system is sick is basically, in many ways, and not saying anything about it, many ways, it helps perpetuate this injustice. So I put a lot of energy into this. I created a human rights, so prior to that, I had already created a human rights organization, a student organization. So I made that one of my priorities, and we started advocating for it. And that the bill that at the time had already been written, the bill, the Safe Harbor Act, we advocated for that, and it became a law in Florida. And that was an incredibly empowering experience. There is nothing for me, nothing better than that, because it's once something becomes a lot, then you are allowed to impact so many people after that, right? Like sometimes like hundreds, sometimes thousands, sometimes millions, depending on what policy you're discussing. But that is just like something pretty fundamental. So when I came to Ohio, I wanted to see like who was doing what here in Ohio. And I went to Columbus and I met Judge Herbert, Paul Herbert, who just retired actually, but he was the first one to start a human trafficking docket in Ohio, right? So he started seeing that he was seeing, so adult women who were being arrested for prostitution, but he realized, wow, these women have suffered so much in their lives, have suffered so much trauma. They're also homeless. They're addicted to substances. They're struggling with mental health issues. What are we doing? Right? We are just like arresting them. They're going back to the streets and nothing's changing and they keep getting exploited. So he created this docket. So what happened with the specialty dockets is like you focus on a specific issue and then you just see people who get arrested for something related to that issue and in the courts. And then you collaborate, or in this case, he collaborated with many community organizations that allow, the opportunity to provide all the things that these women needed. So he put me in touch with a judge here, Heather Russell, who had created this specialty docket here in Hamilton County several years ago, about 10 years ago, more. So about 3 years ago, I met her and we started collaborating and I became part of her treatment team. And I just, I started working on a collaboration between UC altogether and the court. So what we see is women who come that are trapped in this vicious cycle of domestic human trafficking, where they had a traumatic childhood, they grew up in deep poverty, they were re-victimized on a regular basis. At some point, the typical story is that these women grew up in the poverty, surrounded by trauma, being abused, neglected, all of that. And then at some point, around age 10 or 12, they start using alcohol or something to calm themselves down as a coping mechanism. Someone shows up in their lives, usually someone who shows up as a boyfriend or something, who introduces them to drugs or exploits the fact that they are already addicted to drugs, or that they want to run away from their homes. And he takes that opportunity to exploit them further into like forcing them into prostitution or coercing them, or just using that they're already addicted or they're becoming addicted to drugs to keep them in this cycle. So it's very sickening, and it's not, so doing individual therapy or arresting them or seeing them in court is just not enough. Like none of those things alone can really make a difference. The way to make a difference is just to organize the whole system that is prepared to treat these women. So we collaborate with about 50 different community organizations to take care of all their needs, which include mental health, physical health, housing, finding jobs, preparing them to keep those jobs and be successful at them. So ideally is for them to be independently economically, financially, to be feel empowered, to take control of their own lives. So many of them, it's very nice when they're able to actually not even, no longer need Medicaid or social services because they are making too much money to actually qualify for it. So we had several of those cases, and that is just very gratifying when they're actually living independently. So in terms of institutional policy, so I'm a big advocate for integrated care. So, and these are some of the issues of like why this is needed, integrated care. So up to 70% of primary care visits are driven by psychosocial factors, right? A 4-year retrospective longitudinal study determined that team-based integrated care was superior to usual care, with demonstrated improvement in medication adherence, screening for depression, diabetes therapy adherence, and decrease in emergency department visits. Though there are some initial startup costs with integrated care, when considered with the overall cost, is less costly than usual care. And then primary care behavioral health integration. So that means and I'm doing that now in the Avondale clinic. So I'm there as a mental health provider working with primary care physicians. So that integration allows PCPs to serve 42% more patients per day, right? So in overall, people are indicating benefit, providers and patients, most of them. Patients are also less likely to use emergency, so 50% less likely to use emergency services, which you must know are very costly to the city, to the state, to the hospital, to the person, and 49% less likely to need psychiatric inpatient care. The reduction in risky behaviors, 39% less for alcohol and 68% for drug use. So imagine that, for Ohio, which is struggling the opioid epidemic. Rise in show rates for special treatment from 5% to at least 55%. And there's a fourfold return on investment. And why I bring this up, because so when I started working on this, changing systems, and when I was little and I started working on what can I do to change the world? My vision at the time was if I educate people on what the right thing to do, I will be able to convince them and they will do it. And then we will all live happily ever after. But that is not the case, unfortunately. People just do not go with that many times, right? And especially in how, in this deeply divided time, when people are very focused on their own, points of views. So in order to change policies, whether it's institutional policies or public policies, what you want to do is just to be able to see what are all the benefits that this idea can bring. So yes, some people will be happy, I'll be happy, but that's not enough. So yes, it's the right thing to do, but that's not enough. Usually you need to look at what's the economic benefits, okay? Because that would open a lot of doors. So when it comes to speaking to management and speaking to politicians and the public. So in terms of educating, so institutional policies and public policies involve a lot of public education. And then, as I mentioned prior, academia, so taking a role in academia, if you're planning to be professors, if you're planning to be educators, you want to become aware of what the research says about the different issues that you are concerned about and use that data to convince others. So personal stories, even in Congress, when you're speaking to Congress, it's helpful to bring up a specific patient stories or personal stories. It could be very moving. It's certainly a great way to present a point and to talk about a problem and to touch people's hearts. But usually you want to use a combination. So you use the stories to bring this to light, and then also use data, what's the evidence. So, and you can't just leave your speech at this is terrible and this is catastrophic and we need to do something, and then leave it at that. You have to also say at least brainstorm or propose some kind of idea. And it's always helpful to do some research review to see what other people have been thinking and have already evaluated in terms of potential solutions. This is another example, right? So I think this is another example of how a lot of people tend to think, well, but psychotherapists, when it comes to racism and discrimination, they're better, right? They're nicer, they're more compassionate. Actually, study finds that there is also racial and class discrimination among psychotherapists. And unless you show it to people, unless you show the information, they won't believe you. In terms of public policy here, again, this is one brief that was just released by the Health Policy Institute of Ohio about a topic that is very that I've been very focused on for a long time. So my 3 areas of expertise are diversity, women's issues, and trauma. So these briefs, so this is the first one, we're working on 2 more. We'll be focusing a lot on those 3 topics. But this has to do with adverse childhood experiences. So this is an example of how once you learn about what the research says and once you understand what the problem is, then you can start like thinking about what are the next steps, what can we do? So if you haven't seen this video, I really recommend you watch it. This is the Surgeon General in California. And she's a big advocate for educating the public on what adverse childhood experiences are. So I'll tell you very quickly. So adverse childhood experiences include emotional abuse, physical abuse, sexual abuse, witnessing domestic violence. So everything that happened before age 18. So all these events that can be traumatizing for a child. Having a parent who has mental illness, having a parent who has been incarcerated, all of that. So what they found, and they have done a lot of research on this, so we now know that when you look at a population that has at least 4 or more ACEs, you can see that about 50% of them will report mood disorders, such as depression, bipolar disorder. About 70% of them will report anxiety disorders. Over 40% substance abuse. Over 50% impulse control disorders. So when you're thinking about minorities and you combine impulse control disorder, substance abuse, and some mood disorder, or even like just one of those, is a really high likelihood that they're gonna end up being contacted by the criminal justice system at some point. And what is very detrimental is that, what is really common actually is that children of color, particularly Latino and Black children, tend to be identified as problematic very early on when in school, and they get expelled at much higher rates than white children. They get suspended at much higher rates, and then they get identified as these like problem kids that have to be like, we have to get rid of. While children who are, so white children or privileged children, more privileged children, get identified as having some type of mental health issues, so they do receive the treatments that they need. And part of this is like obviously systemic issues in terms of racism and discrimination and major failures from the system as a whole. But there's also the other side of that too, is that there's a lot of bias and a lot of stigma associated with mental health. And the stigma is very, very pronounced in communities of color. So communities of color have historically been good at advocating for themselves when it comes to like housing, employment, but when it came to mental health, not so much. So because sometimes they don't see it as a problem, or they are not able to identify it properly, or they don't want to be seen as having, they don't want to be seen as having a child who has a mental health issue, they don't advocate for a change in that regard. So that is very problematic. So that's part of the reason why I think it's important to change the policies as a whole. So you don't leave it to individual people. You don't leave it up to an individual teacher to decide whether or not to do this. You don't leave it to an individual parent to decide whether or not to do this. You apply it to everybody, right? So like if you are providing integrated care for everybody who comes to see you, then everybody will get it and there's no stigma attached. Make sense? So for schools, for instance, they will many schools have implemented social emotional trainings, and they have also counselors at the schools. So that's a way to target this and overcome those barriers and stigma. See? Okay. Let me go quick now because I want to make sure we have a time for questions. So then the impact on physical health of ACEs is significant. So people who have 4 or more ACEs are twice as likely to get cancer, almost twice as likely to get diabetes. They're 4.3 times more likely to get COPD. And the higher rates remain even if you take away the health risk behaviors. So here in health risk behaviors, yes, they are more likely to engage in health risk behaviors such as smoking or overeating. But even if you take that away, you still see that they have worse healthcare outcomes than people with no ACEs. So this one is very significant for us. So the impact of ACEs on addiction, people who have 5 or more ACEs are 7 to 10 times more likely to use illegal drugs, report addiction, inject illegal drugs. And this is more information, and I can send it to you by email afterwards. But this is how addressing ACEs in Ohio will change different outcomes. So depression will be 36% potentially preventable, smoking 33% potentially preventable. This is the whole kind of like trajectory. So we start with like historical trauma, generational trauma, then changes in social conditions, local context, adverse childhood experiences, disrupted neurodevelopment, and then social, emotional, and cognitive impairment, adoption of health risk behaviors, disease, disability, and social problems, and early death. In the early death, when you compare people who have 5 or more ACEs, for instance, they are expected to live 20 years less than people with no ACEs. And this is more research that I can send you. So important research that has been done, important briefs that have been published on issues that are relevant to you, to what you do. So on racial trauma and healing. So as you know, racism is a public health crisis. 66% of Black people report high levels of day-to-day racial discrimination. So these frequent potential traumatic events influence a person's allostatic load. So this is a physiological indication of repeated chronic stress, wear and tear on the body. So I have, and this takes me to another area that I mentioned at the beginning, so media and technology, which is another way to impact people. That's why I've been involved with the media from very early on. So when I was 10 years old, I started writing for a newspaper. I had a radio show at 12. I was in 3 documentaries. I was very, very involved in media because I understood that media is incredibly powerful. You know, you can educate so many people at once, influence so many people at once. And most recently, I decided to move on into social media. So I collaborated with local and national media many times over the years. But then I started moving on this year more towards social media. But this is an example. So this is a video that I did with a colleague, another psychologist, on racial trauma. There are another more articles that talk about, in this case, so state level policies in psychiatric morbidity in lesbian, gay, and bisexual populations. So as you see here, so state level policies are associated. So state level policies that go against LGBT rights tend to be associated with increased rates of generalized anxiety disorder, post-traumatic stress disorder, dysthymia. So this is another way to, another article that shows how by changing policies, you can impact so many people at once. This is in regards to transgender individuals and the association between recall exposure to gender identity conversion efforts and psychological distress and suicide attempts. So articles like that have been used by people to speak to their representatives. I have done it myself. I went to Capitol Hill to speak about that, but it's just kind of like, okay, this is wrong, we have to change it. This is harming people, it's associated with suicide. They should be we should ban gender identity conversion efforts. And we have been successful in many places by doing that. Another example of this is like showing the toxic stress, the trauma that can come from family separations at the border. And this was done by the president of the American Psychological Association. Most recently, this is another example of how people have become, professionals, physicians, leaders in the healthcare field have become more and more outspoken about, what needs to be done in terms of public policy. So this was by the New England Journal of Medicine, and it spoke about the failure of the prior administration now, well, still current, but it will end in January. Just showing how that failure led to a significant rise in COVID-19 and death. Right? And then more about disparities specifically. So this is basically a YouTube channel that I created to promote a specific mental health techniques in English and Spanish. So I see that as a way to reach more people. So it has allowed me to see a lot more patients, because what I do now is I see a patient, I direct them to specific skills that they can practice at home, so they get better faster, and I can see more and more people, right? And then I already have 12,000 views and people from many different countries across the world watching. So I think it's a way to also connect to people that I would have never had the opportunity to connect. So in the channel I put, besides mental health techniques, I also talk a lot about social action. And now we got to questions and answers. Oh my God, I don't know how much we have left, but you tell me. Thank you, guys.
Thank you so much. Yeah, we definitely have at least 5 to 10 minutes for questions.
Awesome.
If anyone has any, throw your name in the chat, raise your hand. I'm gonna go ahead.
Okay.
Hello, Dr. Espinola. Thank you so much. One of my questions is, what would you say to someone looking for help with their mental health who doesn't know where to start?
So I think the first thing, and I'm gonna send you a guide for this, because I think the first thing is I always ask people to rate their stress from 0 to 10. So 0 means no stress at all. And I done a meter with cartoons. So 0 stress at all is what my cat has. My cat doesn't pay rent, he doesn't care about who's president, he's just cool. So 0 stress is actually not very helpful, because if you have 0 stress as a medical student, you're not even gonna study, right? Why would you? No, you're just gonna be hanging out at home. So you need a little bit of a stress to actually get stuff done. Ideally, you want to keep it 1 to 2, 3 every day, and you're cool. So that's normal. The idea with therapy is never to eliminate all the stress. It's to actually keep you at a reasonable, manageable level. When we get to 4, that's when things start to get more difficult. And in 5, 6, increasing to that up to 10, which is the time when you feel like you're about to harm yourself or do something harmful to yourself or others. So depending on where you're at in that scale, I recommend different things. If you have been thinking about harming yourself or another person, or doing something that could be harmful to your career, yourself, could be using drugs or dropping out of school, things like that. If you're at that level, in a crisis, I do have a specific skills for that can get you out of that crisis pretty quickly, actually. So, and then I also, if that doesn't work, I do have a videos that promotes I call it the crisis survival skills. And then I also have resources, so international resources for suicide prevention crisis lines. If you are at between 7 or more, I start recommending grounding skills of high intensity. So I have a video that shows what to do in those cases, and that's what we would use at the psychiatric hospital to get people out of pretty severe panic attacks, crisis too, just moments when people feel like they are lost, they can't think clearly. And then I have, grounding skills for like when the stress is 5 or more, and when it's 4 or more, it's just like more, it's just everyday type of grounding skills, breathing skills. It's just therapeutic skills that can help you go with like day-to-day stress. Then I also talk a lot about like coming up with a whole plan of how to live a better life altogether and reduce the vulnerability factors. So reduce the chances that if you were to face a crisis, you will engage in a very problematic behavior. So I'll explain, because it's really long, but like I'll explain the guide after, when I'll send it to you. But that's pretty much, some of the basic guidance that I give to people. And then ideally, if people have the opportunity, the thing is like, it would be great to say like, just go and get therapy. And I hope a lot of people can do that. But the reality is that there are like very long wait lists oftentimes. There are barriers in terms of people, lacking health insurance, lacking transportation, not having enough time, the stigma and everything else. So I think that besides saying like go to therapy, we need to give other type of approaches, I guess. So that's what I will send to you. Thank you for the question.
Jonathan, did you have a question?
Thank you, Dr. Espinola, for presenting to us. I wanted to ask you more about your advocacy work.
Yes.
So you said that you had a lot of success in Florida. I was wondering, how has your experience been in Ohio? What have been some of the unique challenges you faced here? And are there any different strategies that you're putting into play here to try and achieve the same level of success that you saw in Florida?
Yeah, I think politically it's actually similar because there's both swing states. So I think in that regard, what I found is that you do have to, no matter what you're trying to promote, you always want to keep in mind that you're going to need bipartisan support. So you need to like expand the ways in which you explain. So first of all, like to actually do research on the issue that you want to promote. Look at everything that has been studied in that regard, and then try different approaches and have all your tools available to you when you're speaking to representatives or proposing a change. So one of the tools could be, like I said, those type of stories that really touch people. Other one is to show like research, right? Other one is like, how this change that I'm proposing will impact the economy in a positive way. So that takes a lot of time sometimes, but if you build up the right connections, you will find enough people who are already doing some of that, and you can collaborate. That's the other point with public policy. You can do things on your own. So the US is an individualistic country, so we tend to think about just thinking very into what you can do as an individual, and that is limited always. So you want to think like, who else is thinking similarly to me, and can we collaborate and come together as a coalition, right? Another important point when it comes to public policy is that you want to, you cannot speak on behalf of the University of Cincinnati, right? You have to, well, you could, but you have to talk to government relations first. So that would be, so if you ever want to do that, you always want to talk to them first and make sure that the university actually supports what you're proposing. I have spoken on behalf of myself sometimes, but mainly in association with other organizations. So the American Psychological Association, the Ohio Psychological Association. So you want to look about what organizations are already supporting this, and then you join them. Make sense? Thank you.
All right, so if we don't have any more questions, I'm going to go ahead and throw a discussion prompt so we can all try to reflect on what we learned in the chat. And thank you so much, Dr. Espinola. We loved having you. And I can't wait to check out your YouTube channel.
Thank you. Thank you, guys.
Thank you.
Have a great day.
You too.